Dear Chairman, thank you very much for your kind introduction. Dear organizers, thank you very much for organizing this fantastic event and also for inviting me to giving a talk on turbinate surgery. In the next 20 minutes, I want to give you a short overview over the anatomy and physiology of the turbinates, diagnostics when patients have problems with the nasal patency, and I want to show you some therapeutical approaches and options you have when you're dealing with such patients. At the end, I will sum up the thing and we'll give you a few key points which you can take home. First of all, anatomy. You all know that we have 3 turbinates on each side of the nose, whereas the inferior turbinate is the turbinate which gives the resistance in the nose for the airstream. This is due to the fact that 70 to 80% of the inhaled air are streaming around the inferior turbinate. You see over here, and then we have the middle turbinate, which is directing the airstream to the olfactorial epithelium and is also covering the ethmoidal cells. And you all know that in the middle meatus, we are starting the functional endoscopic sinus procedures. So this is a very important landmark we will see later on. When you have a closer look to the anatomy of the inferior turbinate, then you find distinct bone in the middle, and this bone is covered by submucosal tissue consisting of seromucinous glands and also venous sinusoids. And these sinusoids are capacity vessels which can swell extensively. So this is the main swelling body of the inferior turbinate. And this submucosal tissue is covered by pseudostratified ciliated columnar epithelium, and this has a coverage of mucus, and this mucus is transported to the nasopharynx, and this is called the mucociliary clearance. Now, what functions do the inferior turbinates have? Due to the anatomical facts I already mentioned, there is a warming function, so the incoming air is warmed up to 37 degrees Celsius. There is a moistening function up to 100% humidity, and there's also a defense function mediated by IgA antibodies. The swelling function of the inferior turbinate also is generating a laminar flow through the nose so that the airstream is really laminar and not turbulent. And due to that facts, it is clear that the inferior turbinate has an important role in normal nasal function and is the influencing factor for nasal patency. Now, when we have a look to turbinate hyperplasia, which are reasons which can lead to turbinate hyperplasia, there we have allergies, especially house dust mite. You all know that house dust mite patients complain about a blocked nose mainly, and also a dry nose, but there are other reasons you see over here which can lead to turbinate hyperplasia as well, like inhalative noxae, hormonal disbalance, systemic diseases, adverse drug side effects. Privinism is a very important factor, and also local inflammation. The result of the turbinate hyperplasia is clear. It is a nasal obstructions with an impairment of quality of life. When the patient is now coming to your practice or to your clinic, what is the diagnostic workup? There should be a really good anamnesis concerning triggering factors. For example, is there any allergic underlying disease, or is perhaps the body position an important factor for the swelling of the nose? This can give you a hint if that the problem is due to the swelling body and not to other problems like septal deviation. Then an anterior rhinoscopy and also an endoscopic evaluation of the deeper parts of the nose should be performed. And they should have a look to the form and the condition of the terminates. Sure, you should look for septal deviations or perforations, signs for chronic rhinosinusitis. And if you have a look to the most upfront part of the nose, you should look for nasal valve stenosis or collapse. After that, normally objective measurements should be done, and this is mainly done with Rhinomanometry and acoustic Rhinometry. So these two objective measurements are, they are in all the international guidelines. They are recommended, and that's why I'm putting them here. But there are a lot more tests you can do, and I will show you later on which these are. Then you should do allergy testing in that patient, especially if you have a hint for that allergy could be an underlying disease. CT scans can also be done, but this is more optional and should especially done when a sinus disease could be possible. What is now rhinomanometry? You all know that measurement. It's an objective measurement of the nasal flow rate. It's very sensitive and highly specific, and it is therefore the international reference method for the patency measurement for the nose. The disadvantage is that it is normally time consuming and therefore expensive, and it's also error prone, and furthermore it needs an active cooperation of the patient, which can be a problem especially in younger children or in disabled patients. So furthermore, there's the problem that you have no possibility to localize the stenosis in the nose. It just tells you that there is a problem. Another measurement where you can localize the stenosis within the nose is acoustic rhinometry. It's an objective measurement of the nasal cross-sectional areas, beginning from the anterior part of the nose to the deeper parts of the nose, and thereby you can localize really stenosis, especially in the anterior part, very well. It's quick and easy to perform. There's no active cooperation of the patient, so it's a good measurement for children, and the reproducibility is very, very good in comparison to the rhinomanometry. The disadvantage is you need an expensive device, and this is, in my eyes, the only disadvantage for this diagnostic procedure. I told you that there are many more possibilities to assess the nasal patency. You can have a look over here. There are many. The first three over here are more common. These are not so common, but I want to give you an impression about numerical flow simulation later on, and this is a fantastic method to show really the results of surgical procedures in terms of nasal airflow, in terms of humidity, and also the air speed, which is generated through surgical procedures. When the patient is now diagnosed, the first step should always be a medical treatment, and this should always be considered before surgery. This is topical corticosteroids, antihistamines. If you think about allergies, and also nasal showering should be performed for 6 to 8 weeks to be sure that medication is not able to improve the symptoms. Then, if medication is not working, we're going for surgical procedures, and you see here the procedures you can do on the inferior turbinate with an increasing invasiveness, beginning with turbinate lateralization, via submucosal tissue reduction and resection to the partial turbinectomy or the full thickness resection of the turbinate up to the total turbinectomy, what should be avoided whenever possible. I want to go through the different procedures now, and I want to start with the turbinate lateralization or the outfracturing procedure. This is due to the name. It gives a good lateralization of the inferior turbinate, but there is no influence on the swelling and the mucociliary clearance due to the fact that the mucosa and also the submucosal tissue stays intact. Therefore, it is often combined with septal surgery, or it is sometimes necessary if you want to bring the septum to the midline. As you can see over here, a straightening of the septum would not be possible without outfracturing the inferior turbinate on the left side here. It is easy to perform, but there are some complications described in the literature. For example, the impression of the medial maxillary wall with some problems in cleaning function of the maxilla later on. Second procedure I want to present you is the laser application. Laser can be easily applicated in an outpatient settings. There is quite a strong effect on the submucosal tissue, but also on the mucosa itself. So depending on the energy you are generating or you are giving to the mucosa, there can be a strong impairment of the mucociliary clearance, and this can cause prolonged healing. And due to the fact that you are normally doing spots like this, you have intact tissue in between, and there can be recurrence of hypertrophy in the long term. The next would be radiofrequency or also bipolar tissue reduction. This is also easy to perform in an outpatient setting. There is low influence on mucociliary clearance because you are going with the instrument in the submucosal tissue, ideally between the mucosa and the bone, so that there is no application of the energy to the bone on the one side and no application to the mucosa on the other side. Due to that, there should be only little crusting afterwards, and no packing is normally needed in that case. More invasive resection of the submucosal tissue can be done with a microdibrider. You see here a vertical incision in the head of the inferior turbinate. Then you lift up the submucosal tissue from the bone, and you can then use the microdibrider to gently reduce the swelling tissue, and afterwards you just push the mucosa back to the bone and you have a widening of the inferior meatus. Due to the fact that the mucosa stays intact, there is barely crusting. The problem is that you have a single-use device in most of the cases, and this can be expensive and is normally not covered in many countries. In Germany, for example, it's not covered by the normal insurance. A next step would be the resection of the bone. You see over here, and also again an incision in the head of the inferior turbinate. Then you lift up the submucosal tissue from the bone, and you can then resect the bone between the two tissue layers. There's for sure no impairment of the mucociliary clearance because the mucosa stays intact. And the good thing is here that you have afterwards no exposed bones. You just lay the two tissue layers next to each other, and this will give a good healing. Normally, this procedure is done in combination with submucosal resection, as you have seen with the microdibrider, and it can be adapted to the facts you can find in the special nose. This is a fast healing procedure normally, as you have no exposed bones and you have no wound healing surfaces, so no crusting. A much more invasive procedure is the inferior anterior turbinectomy. This is a resection of the anterior 2 to 3 centimeters of bone with the lateral submucosal tissue. So you have a mucosal submucosal flap over here, and this is laid over the exposed bone and then just a little bit packed with some nasal packing to hold it in place. The good thing is you have a good widening of the cross-sectional area in that part of the nose. There is no bony edge which is exposed, and the swelling mechanisms of the submucosal tissue is preserved, also in the mucociliary clearance. What is a negative fact is that in up to 20% of these procedures there is postoperative bleeding, and this is a little bit higher than in other procedures. Now I want to come to the full thickness resections, the partial turbinectomy, and I will present you here the strip resection. You see, you just take a scissor and then resect the inferior part of the inferior turbinate, and this is for sure combined with the loss of mucociliary function, because you are losing mucosa, you are losing swelling tissue, and you have the problem with exposed bones in this area. So there is normally prolonged healing with crusting, and you have to do debridement in the long term to get good operative results. What you can definitely, or what you do when you are resecting these parts, you are really generating changes in climatization function of the nose, and I will show you that over here. This is a CT scan where a single-sided partial turbinectomy was done, and this CT scan was used by a working group from Ulm to do a numerical flow simulation. So there was a simulation concerning the airflow velocity. You can see over here in the frontal part of the nose, in the middle part, and in the nasopharynx. You can see the temperature changes and also the air humidity changes. And what you can see on that side is that you have a higher airflow through the nose, and this can be seen also in the nasopharynx. This higher airflow velocity is generating a lower air temperature in the nasopharynx and also a lower air humidity, and this can have influence on the deeper airways as well, and can generate crusting or a drying of the nose. The last procedure on the inferior turbinate I want to show you is the total turbinectomy. This has definitely a loss of climatization function afterwards and should be avoided whenever possible, except surgery of tumors or when you need a megaosteum to the maxillary sinus. The problem with the patient could be that even if you have a good view through the nose, there is a missing airflow detection on the surface of the turbinate, and the patient is complaining about a blocked nose. Furthermore, if you combine this procedure with radical sinus surgery, you can there can be an empty nose syndrome with crusting and long-term problems, and also synechia can occur after this procedure. Especially if you are cutting the deeper part of the anterior turbinate, think about bleeding of branches from the sphenopalatine artery, which is a big vessel, and this can bleed immensely. What is the postoperative treatment of these patients? Most of the procedures I showed you can be done in the outpatient clinic. Normally there is no nasal packing necessary in that cases, but the patient should clean the nose with saline irrigation and brushing ointment, and there can also be painkillers prescribed if they are necessary. If you are going for more invasive procedures, then nasal packing could be helpful to hold especially mucosal flaps in place. And what is really important in the long-term outcome is postoperative evaluation of the healing process, and if it is necessary, mechanical debridement of crusts and also of synechia. Now I want to flip to the middle turbinate. I want to show you three, I think, important possibilities to do procedures on this turbinate. Also with an increasing invasiveness. We begin with the middle turbinate medialization, then the narrowing of the turbinate. This is mainly the Concha bullosa resection. And last but not least, the middle turbinate resection. What should be avoided whenever possible, but when we have a look into the literature, is often not a problem for the patient in the long run. So the middle turb medialization normally is used after functional endoscopic sinus surgery, and you can do that by making a suture through the middle turbinates, through the septum, and then doing a knot in front of the turbinate. And you can see you have now a nice view for the next few weeks to the ethmoid. And this suture is normally resorbable. And you see over here, after 2 years, there is a very nice standing of the middle turbinate. This is normally a temporary medialization if you take the suture, but you can also induce a permanent medialization by inducing synechia. Therefore, normally there is an incision or an incision done in the septum and also in the middle turbinate, and then afterwards you see a synechia like here, which holds the turbinate more medially, and you see this middle turbinate is tending to lateralize, but due to the fact that there is a synechia, it's open enough to have a good view and also a good cleaning function. The second step would be the narrowing of the middle turbinate. You have the CT scan over here. You know, Concha bullosa is normally an anatomical variant. It's not pathologic. And this anatomical variant can compromise the osteometal complex, and therefore a reduction is necessary. And what we normally do is we resect the lateral aspect of this concha by doing an incision with a chisel knife, then going with a scissor, cutting through that to the back parts, and then removing the lateral aspect, as you can see over here. And now you have a nice view to the bulla ethmoidalis. And this is the starting point for further functional endoscopic sinus surgery procedures. What is important to mention is if you are cutting in that part, in the deeper part where the middle turbinate is going to the lateral wall, there are the big branches from the phenolpalatine artery, and these branches should be preserved to avoid postoperative bleeding. Last but not least, middle turbinate resection is a controversial aspect of functional endoscopic sinus surgery. It facilitates access to the operated ethmoid and prevents scarring. But on the other hand, if you are cutting out the middle turbinate, you are losing an important landmark which should be preserved for later, perhaps revision surgery. But if you have a look for the problems the patients have after such a turbinectomy, these problems are little. So endoscopic scores and quality of life scores normally were not negatively affected by a resection of the middle turbinate. Important to know is if you are doing a resection very high up to the skull base or a avulsion, that can lead to CFS leaks and also to smell problems, and that should be avoided. I want to sum up the thing now for you and try to give a short overview. So what is important? Important is to try to preserve or restore normal nasal function if you are doing procedures on the turbinates. The most conservative treatment that can accomplish that goal is normally the best options. Preoperative evaluation is crucial to get an impression where the problem really is. For sure, medical treatment should always be the first step before you're going to take the patient to the OR. Greater resection. Ablation should be used for conservative treatment failure. If you're not, or the patient is not happy with the goal you are reaching, then you should go up to a more invasive procedure. And what is also very important is the postoperative evaluation, and the debridement is very important to avoid synechia and get a good wound healing, and this will lead you to a good long-term result. I want to thank you very much for listening, and the discussion is open now. Thank you.